All right, so for those of you who don't know me, my name is Yaninia Pasikhova. I'm one of the ID pharmacists over at Moffitt Cancer Center, and today we're actually going to talk about Nocardia, but I just wanted to approach this a little bit differently than just talking about a disease state. We're going to talk a little bit about a patient case and then look at some of the risk factors, at least that we found in our patient population, or particular in our transplant patient population with Nocardia infections, and specifically kind of focusing on prophylaxis with Bactrim that we use for our patients for PCP prophylaxis starting at day plus 30 to day plus 28. So the objectives for today is to discuss a patient case, discuss presentation and management of nocardiosis, and describe some risk factors in transplant patients, specifically our internal data that we just published for 10 years worth of transplant patients with nocardia infections, and then we'll conclude the patient case. So, for those of you who have not been over to Moffitt, I know it's a lot of abbreviations and they're all there for you on the bottom, but we'll just talk about it. AB is a 58-year-old male with history of AML, status post allogeneic mismatch, unrelated donor transplant, and he's day plus 183 from his transplant. He had a reduced intensity conditioning regimen, and his graft versus host disease prophylaxis was TAC and Cyro. And really, his post-transplant complications was acute graft versus host disease of the skin, grade 2, for which the patient was receiving prednisone. So the chief complaint when he presented to clinic was, my back pain is out of control and I feel like I have a fever. So the HPI, the patient was in the usual state of health until 3 weeks prior. He was working on furniture and developed increased back pain at the bone marrow biopsy site, which he had 1 week prior to this incident. Patient reported minimal relief with oxycodone. So he contacted the BMT treatment center, like we tell all our patients to do if they have any kind of complications or something is not being controlled. But he was, kind of a tough guy. Said, I'm going to hold out for a week, right? So this was progressing for about 1 week. And on physical exam, they reported that there's mild erythema at the bone marrow biopsy site. Everything else was kind of within normal limit. And I say for the patient because our patients' labs that are normal for them may not be normal for some other patients. The patient was given cephalexin 500 milligrams POTID for 14 days. His pain meds were increased, and a follow-up appointment was made at 2 weeks. And the patient was to call the treatment center if something changed in the meanwhile. So if the pain got worse, if the patient became febrile. So at the follow-up appointment, patient reported no improvement of pain, subjective fevers at home with chills, but he never measured his temperature. Patient's wife reports decreased appetite, increased fatigue, and then on physical exam, they did report that the erythema looked worse at the bone marrow biopsy site, and they did document the fever in the treatment center of 38.8 degrees Celsius. So our febrile patients post-transplant, neutropenic or not, if we're not able to control things with outpatient antibiotics, will get admitted, which this patient did. So just a little bit more about the patient, the past medical history. The patient is an AML patient, status post-induction chemo with 7+3. He did have complete response, so CR1, and received a transplant, a mismatch unrelated donor transplant. As we said, he had acute graft versus host disease of the skin, chronic back pain, and diabetes, which was steroid induced, right? So we'll see a lot of that in our patients because they will receive steroids for a prolonged period of time. So some pertinent medications that the patient presented with, he had his cyclovir prophylaxis, so 800 milligrams PO BID. All of our patients received this for a year or longer while on immunosuppression. Cephalexin 500 milligrams PO TID. He was day 13 of the 2 weeks that he was to take them. His oxycodone, Pantam nebs, we use that for PCP prophylaxis, and you'll see our BMT attendings will tend to use pentamidine nebs in patients who don't have great count or patients who report a sulfa allergy, where other attendings will actually desensitize patients on the outpatient setting to give them Bactrim prophylaxis, only because it provides, also coverage for toxa, right? If they don't want to give metoprolol, or it's just expensive. His other immunosuppression was Cyro and TAC. No known drug allergies, he denied history of tobacco, alcohol, and a really remote history of marijuana use. So in review of systems, the patient had he was fatigued and lethargic, decreased appetite, subjective fevers and headache, and pain at the bone marrow biopsy site, which patient reported as 8 out of 10. The vitals are there for you. So patient is tachycardic, respiratory rate of 25, BP is fine. He's alert and oriented times 4, but there is erythema at the bone marrow biopsy site. So patient gets some labs done, micro done, so MERS and VRE screen, that's standard for any patient that gets admitted. We do blood cultures times 3, so most of these patients will still have a port, right? And a peripheral culture was done. Urine cultures, CMV PCR, EBV PCR, not really sure why we pulled them, but it's a febrile transplant patient, so you'll see commonly they'll get pulled. And so these are the patient's labs, and they said they were kind of with the normal limits for the patient, right? So these are not necessarily normal for normal patients. So the patient is not neutropenic, right? He had an ANC of 2.18, just some mild creatinine elevations and some thrombocytopenia, but nothing too impressive for the patient. So a chest x-ray was done, which was negative, and then an x-ray of the pelvis was done and showed soft tissue swelling, fluid collection, and basically said that osteomyelitis of that area cannot be ruled out. Patient was started on Cefepime 1 gram IV Q12 hours, and then blood cultures were called positive at 1 out of 3 as gram positive rods, right? So very often we'll think of gram positive rods as being a contaminant, especially when growing in 1 out of 3 of the blood cultures. But then micro went ahead further, gave us some additional information, said that they're branchic, filamentous, beaded, modified AFB positive. So now an infectious disease consult gets called, right? Do we just add bank? Do we think this is a contaminant? And so before we discuss this further, I just want to go through what are the infectious complications that we expect in transplant patients. As Dr. Baluch knows, this is my favorite slide and hers as well, and it's really nice graphic representations of what infections we're concerned about in patients at the time of transplant. So we're going to be focusing on these late presentations, right? So you'll see bacterial, encapsulated bacteria, VZV, and then fungal, and pneumocystis is included. But if you notice, really doesn't discuss Nocardia as an infection to be considered. So Nocardiosis, a little bit on the background. It's an opportunistic infection, and I have this in quotations. Does anyone know what percentage of patients have no immunosuppression when they're diagnosed with Nocardia or are not immunosuppressed at diagnosis? It's about a third. So about a third of patients don't have any underlying immunosuppression or immunodeficiency. It's an aerobic gram-positive, partially AFB positive, catalase and urease positive, non-motile branching filamentous bacilli. And you can find it almost anywhere in the environment, right? Whether it's the soil, it just kind of hangs around there. And if you've ever seen Nocardia in microlab, that's kind of what it looks like on the gram stain. Very pretty. It was first identified in 1888 and then recognized as a human pathogen 2 years later. And primarily the infections are acquired through inhalation, right? So you inhale the organism, so it settles in the lungs. You get pulmonary infections. You can get direct inoculation of the organism right into the skin or into the bone. So you can get cutaneous presentations as well. And remember, Nocardia loves the brain, right? So just like you can see it in the lungs, you can also see it very frequently in the brain. So there's over 80 species that have been identified of Nocardia, and every time the nomenclature changes, right, as we're getting tests that are better at able to pick up the differences between the organisms. All these complexes that we used to call them are now being separated out, right? So as we're getting PCRs and all those things. So the most common species that we see are Nocardia furcinica, Nocardia nova, and then Nocardia brasiliensis. Anything in particular about Nocardia furcinica that is really important to keep in mind from a drug susceptibility pattern? So this tends to be one of your more resistant species, and it's intrinsically pretty much resistant to third generation cephalosporins. So just something, again, to keep in mind. So what are some risk factors for developing nocardia infections? Like we said, some patients do not have any, impaired T cell mediated immunity, but things like alcoholism, cirrhosis, steroid use, HIV, AIDS, and allogeneic hematopoietic stem cell transplantation. So interestingly enough, we don't very frequently see this in our HIV patients, particularly because majority of them with such low CD4 counts are going to be on background prophylaxis. Just something to keep in mind whether or not there's actually a role of this drug in, in helping prevent nocardia particularly. So some other risk factors, right? Renal failure, sarcoidosis, solid organ transplant, and a variety of vasculitises, whether it's from the vasculitis itself or the fact that patients are getting steroids for the management of the vasculitis. So how is it going to present? Well, most commonly we said, you're going to inhale the organism, so pulmonary presentations. And then you can have extrapulmonary disease, right? Whether it's a disseminated hematogenous spread, which is more common in your immunosuppressed patients, or it could be a contiguous inoculation of the organism outside of the lung, right? So someone's gardening and then they get a prick and then it's in their finger, right? So that would be the contiguous inoculation. So pulmonary, right? Nothing. Again, you can look at images and say, well, this is a typical presentation of whatever, 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 but you really can't tell what the organism is just by looking at a CT scan, right? So, because a lot of things can look the same. So that's a brain abscess with culture-proven nocardia, right? You can see it really nicely. Look, it has a pharmacist sign, right? You can see it right there. Oh, so this is a superficial skin nocardiosis that you're seeing there, more of a chronic type of presentation. Here you have a lymphocutaneous nocardiosis, so you see how it goes. The spread is like you have these nodules, right? Nodule lesions, and it's as a lymphatic spread. And then Madura foot, also nocardia can present this way as well. Now here you can have disseminated disease, so you see it in the brain, in the lung, and then in the skin, and it was all culture proven. Okay, so in terms of treatment and prophylaxis, interestingly enough, there are no treatment guidelines, right, for the treatment of nocardia. So if you look at IDSA and you try to find IDSA recommendations for the treatment of nocardiosis, there really aren't any recommendations. As you can imagine, there's not very many randomized controlled trials, right, looking at this. It's not a very common disease, and so there's just lack of data. In terms of susceptibility, there's poorly standardized in vitro susceptibility testing, and then there's minimal data that actually correlates in vitro susceptibility to clinical outcomes. So it makes it really hard. And we know this for some of the other organisms, like your rapidly growing mycobacteria, right? We know that as well, that in vitro susceptibilities may not predict whether or not the patient is going to clinically respond to therapy. And of course, because we're always changing the names, right? So it's really hard to then compare what are the outcomes of one, patient population versus another, because now the organisms were renamed or they grouped together. So even for us, the data that I'll show you, some of the organisms that we grouped together at that time or were not able to identify, it was either due to the lack of the test or the sensitive test 10 years ago that we pulled this data from. So in terms of what you can find in terms of treatment recommendations, number one is get susceptibility data, right? If we can't do it internally in our hospital, we send it out, right? So we send it to a reference lab. Don't assume that it's just going to be susceptible to where you're empirically going to start the patient. So for non-severe infections and immunocompetent patients, you can do monotherapy with an oral agent for about 3 to 6 months, but if it's a mycetoma, 6 to 12 months is recommended. Now, for immunocompromised patients, you can also do for mild disease oral therapy, but you're going to end up doing it for at least 12 months. Number one, it's because the response is just slower, and number two, as long as they have ongoing continuing immunosuppression, the risk of reoccurrence of this infection is just super high. Now, severe infection is defined in the literature as either pulmonary disease, CNS disease, disseminated disease, or all infections with greater than one site in an immunocompromised patient, right? So if your patient has more than one site involved and your patient's on prednisone and Cyro and TAC, that's considered severe disease, even if it doesn't look severe to you, right? So by definition. So we're going to do combination therapy for majority of these patients, anywhere from 2 to 3 drugs, depending on the severity. You want to start off with IV probably for about a month, so about 4 weeks of IV therapy. Then you can switch to oral therapy. You can do, again, uncomplicated patients, those who rapidly improved on IV. You can argue for PO monotherapy after 3 to 6 weeks. And then for complicated cases, usually you want to do combo PO therapy for a minimum of 6 weeks. Total duration is usually going to be 6 to 12 months and minimum of 12 months in patients who have CNS disease or are immunosuppressed. So, first line drugs. So I think I can actually open this up and kind of empirically, if you were to treat a patient like you had that patient case, right? You don't know what it is yet. You don't know. You have an idea that it's probably Nocardia, but you don't know the species or anything. So what empirically drugs do we use to cover for Nocardia? So one is up here, right? It'll be Bactrim. You're going to go about 10 to 15 mg per kg per day of the Trimethoprim dosing, right, of the Trimethoprim portion and divide it into 2 to 4 doses. However, remember, some groups, depending on where you are geographically and what was the most common organism, report resistance rates as high as 60%. So we're saying we're going to start off with combo therapy, right, kind of considering this. So we'll do Bactrim plus what? Yeah, imipenem. So imipenem is actually the drug that's been studied the most, right? And so it is actually the preferred carbapenem. That's not to say that meropenem doesn't have activity. Unlike with rapid growing mycobacterium, where imipenem is the only carbapenem that has activity against the rapid growing mycobacterium, right? So yes, imipenem and then an aminoglycoside like amikacin, right? Also would be the most common things that we try to start patients on. So what other drugs have activity? So we said imipenem, amikacin. What else? Linezolid. What else? Minocycline. What else? Yeah, exactly. Let's go in there. Your lower end antibiotics, right? Ceftriaxone, very convenient for patients, right? I mean, if they were going to be inpatient, we do 2 grams Q12, but then eventually if we wanted to transition them out, you can probably get away, if that's not a CNS infection, to 2 grams daily. We said minocycline and then quinolones, right? You want to get susceptibilities, but you can definitely get as well as an amoxiclav is another one that has activity against the drugs, against the organism. I put tigacycline in there. My main concern always with tigacycline is just tolerability for patients, right? Patients tend to develop severe nausea, vomiting with this drug, and so at least for when it's being used for rapid growing mycobacterium for prolonged courses, lower doses are used than what we would do for gram-negative infection just to increase tolerability. I clinically have never seen tigacycline be used for Nocardia, but it does have in vitro activity. Just in general, this disease is associated with significant morbidity and mortality, as high as 60% in some immunosuppressed patients. Now, in terms of, so we know once you get the infection, your chances of dying are kind of high. So what about prophylaxis, right? Should we be prophylaxing these high-risk patients? And so it's not routinely recommended, and only because the data is conflicting. So some studies have shown that, look, patients who get Bactrim prophylaxis don't get Nocardia, where other studies did not show any protective benefit for prophylaxis. So we were actually prompted to look at our patients because we had like a run of Nocardia. It felt like every 2 weeks there was a patient who came in with a Nocardia infection. And knock on wood, it's been a while. So we went ahead and actually pulled some of our own internal data that you can find just recently been published in Transplant Infectious Disease. And so this was a retrospective chart review over a 10-year period at Moffitt, and we included stem cell transplant patients with a diagnosis of Nocardia. Baseline characteristics, underlying disease, immunosuppression, and prophylaxis were all collected, and we tried to see what were some clinical features, treatment regimens, and outcomes. So patient was said to have Nocardia if they had at least one positive culture from a respiratory, blood, or wound source. Then hopefully the Nocardia species isolates were identified at Moffitt, but then they were sent to a reference laboratory for speciation and susceptibilities. So in 10 years, we were able to identify 15 cases, and I know you may not think it's a lot, but it's actually a lot. When we presented this data at a national meeting, some of the other transplant programs were actually very surprised at the number because this is a significant number of patients. So 15 cases of Nocardia were identified, specifically in allogeneic stem cell transplant patients. Majority were males with 55 years as the median age. And these are all, and I'm going to actually skip. All right. So this is all 15 patients, kind of baseline characteristics and outcomes. You can take a look at this if you want. This is just all the data summarized, but we'll just go through all our results separately. And so I'm a visual person, so it's nice to look at graphs. In terms of transplant type, we found it really interesting. The majority of the patients were actually a match-related donor. And the reason this was surprising is you don't expect these patients to be the most immunosuppressed. You're actually mismatched, or your patient should have more immunosuppression. Not surprisingly, the type of conditioning regimen that was most common was your myeloablative conditioning regimen instead of your reduced intensity. So in terms of graft versus host prophylaxis, most of the patients were on TAC, MMF, and PRED, right? But then if you look in general, all different types of, GVH prophylaxis regimens, prednisone was pretty much present in all of the patients, right? And we actually took that part out, and we can look at it closer in a little bit. We were good about giving PCP prophylaxis to our patients. 100% of our patients were receiving PCP prophylaxis, but only 20% of them were actually getting Bactrim. And the ones who were getting Bactrim were receiving this lower dose Bactrim prophylaxis, so either the 1 BID twice a week or 1 TID, like Monday, Wednesday, Friday type of dosing, so the lower doses. So none of these patients were on a single strength daily or a double strength daily, right? Then we looked at the site of the infection, and not surprisingly, lung, either by itself or some sort of combination of site, was the most common, right? So whether it was lung blood, lung brain skin, lung blood, or some other fluid. So as we said, tend to inhale the organism first. So interesting for us, up to 20% of the species we just could not speciate, or were not speciated at the time. But the most common that was speciated was actually Nocardia nova. And so we had susceptibility data for 8 of the isolates, and 100% of them were susceptible to amikacin, linezolid, and Bactrim. So interesting enough, even the patients who broke through while on low dose Bactrim, they still had a susceptible organism. So 14 patients received antimicrobial therapy. So one patient went to hospice at the time of diagnosis. So 93% of them received combination therapy with greater than or equal to 2 drugs for at least 2 weeks. And out of those patients, 77% had a carbapenem-based regimen. And the median duration of therapy was 25 weeks. In terms of how did the patients do ultimately? So disease resolution, it was documented in 8 patients, so 8 of the 14 treated patients. So about 57% had resolution of the disease. In terms of infection-related mortality, We had about 67% infection-related mortality, which associated with treatment failure. Again, these numbers are really small, but you can still see when these patients do develop the disease, they don't do as well. So this is back to kind of summarizing all the things that we just looked at, but what was really interesting from all of this was the fact that 12 out of the 15 were on some dose of prednisone. The median dose of prednisone was actually 20 milligrams per day, and 10 patients out of the 15 were receiving at least 20 milligrams of pred per day. If you also look at there was the other interesting point here. We talked about, in terms of pulmonary disease, like we said, it was almost 90% of the patients, and almost 50% had disseminated disease, meaning two non-adjacent contiguous sites, right? Or, isolating it in the blood. So what was interesting for us, we think of immunosuppression in general. Oh, the patient is neutropenic. We all look at the neutrophil count, but look at our patients here, right? This was tended to be a late presentation of transplant. Almost none of the patients were neutropenic at the time, but look at their absolute lymphocyte count. So lymphopenia was something that we actually saw more so than neutropenia. And again, the median time from transplant was 10 months, right? So that's another thing important to keep in mind. So then we wanted to see, okay, so the patients who did respond versus the patients who didn't respond to therapy, was there anything really different? And we can't do statistics on these small numbers. We're not powered to do statistics, right? So this is just for us to look at. We found that patients who developed the disease earlier in their transplant course tended to do worse than those who developed it later on, right? Because you probably have some degree of your immune reconstitution and getting some of your counts back. And also the degree of lymphopenia was different between the two groups. So if you look at patients who failed therapy, they had profound lymphopenia, or I can't say that those that had resolution did not, but they're better counts. So just to, again, conclude all of this, we did find that this was a late complication of transplant, and the only thing that we could see that lymphopenia and prednisone use tended to be factors that predisposed these patients. Lack of Bactrim prophylaxis, at least in our patient cohort, appeared to correlate to developing the disease. Majority of patients that we did treat were treated initially with a Bactrim-containing regimen. So the patients who were not on Bactrim prophylaxis weren't on it because they were allergic. The most common reason was they had bad counts, right? But then when it came time to treat the infection, now we're pushing these doses that are, 10 to 15 milligrams per kilo. That's when you're actually starting to see more myelosuppression would be with the higher doses of Bactrim, not the prophylactic doses. So just back to our patient to wrap it up. So once ID got consulted, went ahead, there's a CT pelvis with contrast that was ordered, and it showed that there's peripherally enhancing abscess in the right gluteal muscular with associated cortical bone loss in the right iliac bone, which was suspicious for osteomyelitis, and the patient did have a CT guided biopsy done of that site. Now, we send that for culture, and now both the wound cultures at the bone marrow biopsy site as well as the blood cultures grew Nocardia for Seneca, and the susceptibilities are there for you. Remember I said Nocardia loves the brain, so we went ahead and we got an MRI of the brain with and without contrast, and as you see, the patient did have a 6 millimeter lesion that was found. The radiologist read it out as this is most suspicious for a small abscess, which is infectious, but neoplasm cannot be completely excluded, especially where we're set in a patient population. I don't think we ever went in and biopsied the lesion. I think the assumption was that this was disseminated disease. I think did a bronch, right? And the second one. So I think the presumption was this is just disseminated nocardiosis, right? We had blood cultures and we had a wound culture, and then empirically. So The final diagnosis was disseminated infection with Nocardia furcinica. Treatment was amikacin, minocycline, imipenem, then minocycline moxie, and then finally just minocycline for 1 year. The outcomes were a little bit tricky in this patient. I have it written down here as outcome failure because isolation of Nocardia species from lung 1 year after. In reality, the patient actually had resolution from the original sites that we saw, and this was a new lung nodule. The patient ended up growing out Nocardia again, but a different Nocardia species this time. So we don't know whether we didn't pick it up the first time or what the issue was. Just for the sake of just presenting, we'll say that the patient had a Nocardia within 1 year. So again, this is our final summary slide, and so just something for you to remember when you're seeing these immunosuppressed patients late from their transplant. I know it's not a common thing to think about, but Nocardia, especially if they're not on Bactrim prophylaxis, is something to keep on your differential. We found just like in the literature, predisposing risk factors to be steroids at any dose, particularly at 20 milligrams per day or more, and having patients who actively have graft versus host disease, right? Because they're the ones who are going to be on the prednisone or the immunosuppression. Not being on Bactrim for PCP prophylaxis, and as we showed, kind of supporting with the rest of the literature that the mortality is pretty high, about 60%. We need better studies to figure out how long to treat, right? But no, it's very hard to do randomized controlled trials when you can get 10, 15 patients in 10 years, right? It's not an easy patient population to do trials on. So I'll kind of leave you with that and open up for any questions. Come on, laugh at you.
The ANC and the ALC, those medians were calculated at time of diagnosis, is that correct?
Yeah, time of diagnosis. So.
Did you have any data about mortality, like how long from time of diagnosis to time of death in the patients that failed treatment?
So we count the failure of treatment on anyone who had either mortality or went to hospice within 1 year. So those that were considered as failure, or it just seemed that patients that did well early and kind of did well, and those who didn't do well just lingered on and just ended up not doing well. And there's
another issue we have at the same time is this patient population. If they have graft versus host disease, especially of the GI tract, and now you're giving them multiple medications every single day, they tend to lose weight. They tend to require additional medication to offset our medication side effects. So definitely in bone marrow transplant patients, this gets very complicated very fast because of the multiple drug requirement needed to treat these types of infections and the
yeah,
prolonged courses.
yeah.
So once the susceptibility comes back, to decide either two drug or three drug, how do you determine?
So that's one of the limitations of retrospective studies. It's at the discretion of the attending. So within 10 years, the variabilities that you have, right, the attendings that are seeing the patients are different. The patients we're seeing may be older. So whatever the choices were here, this was completely left up to the attending. And there isn't much recommendations to do triple therapy after having susceptibilities and after initial IV course. So once they're outpatient, or even the step down would always be to two or to one agent. Especially you're thinking long term. You just want your patients to tolerate the drugs, right? So at least something. You don't want. I mean, it's really hard to tolerate 12 months of 3 drugs. So at least for our patient, once we had the susceptibilities and once everything kind of was cooling down, that's when we transitioned to 2 drugs, then to a single agent, where whatever was done here was completely at the discretion of the attending. And again, you could see it completely varies. You have, meropenem, imipenem, minocycline, whatever it was. So with no consistent, um, choices. All right. All right. Thank you.